Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today, we're going to talk a little bit about what has been traditionally called Morton's neuroma, neuroma pain, forefoot nerve pain. We are trying to sort of get rid of that nomenclature because I think the neuroma nomenclature sort of implies this bulbous, inflamed nerve, and that's not always what we're dealing with. Most of the time we're dealing with just an irritated nerve that doesn't look that much different than the nerve next door, but it can cause all kinds of burning, tingling, shooting pain, numbness in the ball of your foot. You can have both the second and third interspace involved. Third interspace is the most common, so between the third and fourth toes. But so the things people are complaining of when you see this in the office, I mean, it's shooting, stabbing, burning, numbness. People say it feels like I'm walking on a piece of
like
cotton a marble.
Yeah.
Feels like I've got rolled up sock in my shoe, and I take my sock and shoe off, and I'm like, there's no rolled up sock there.
Yeah, and it'll be in the distribution of that nerve path, so you can kind of trace it back to where it is. So if it's in the fourth interspace or the third interspace, more commonly, it'll be numbness between that third and fourth toe. And, if you're able to palpate or exacerbate it, they'll...
You pinch in there, and they've got, a pretty significant and response to that. You're going to get the cringe sign where they really don't like it. They'll come out unglued sometimes.
It's called the Mulder's click. When you pinch it and you kind of squeeze those metatarsals together, pushing that nerve up in between those metatarsals.
You can feel it flick back and forth. Yeah. But that hurts, and that's a pretty good indication that there's an entrapment site there.
So is it a neuroma or is it more neuritis?
It's really interdigital neuritis, because I think the neuroma term implies that the nerve's been cut, and now you've got this bulbous mass of nerve stump. Exactly. Yeah. You basically have a stump neuroma, and those can happen anytime you've had any sort of laceration of a nerve. They can happen in amputees, people who've had a toe or a leg amputated. So essentially, anybody can develop one of these if you've had an amputation or a laceration of the nerve. Yeah. Oftentimes the nerve just doesn't heal well, and it ends up curling up on itself and becoming this massive ball of painful nerve endings.
Yeah, it's like a little fiery poker in your foot where you just can't get rid of that pain.
And so unfortunately, for the last 100 years, the traditional treatment for this, if non-surgical options have failed, is cut the nerve out.
Yeah, this neuritis, not this neuroma.
And it's the only nerve entrapment in the entire human body where our first choice has traditionally been to cut it out. It doesn't make any sense. Yeah. Right? You wouldn't do that in the hand. Why do you think it's a good idea in the foot? So anyway, that should be your last resort. And so your original options, when things like maybe a steroid shot or two don't seem to help, maybe changing shoe gear.
Shoe gear, stretching, steroid shots.
Clearly wearing tight shoes is going to compress those metatarsals, diminish the space that nerve has to live in, and you're going to have problems. But this is a great picture. I think the misnomer is that the nerve has to look like that in your right-hand picture there. Yes, the nerve's getting irritated by the ligament, but they don't look like that oftentimes. They can be this spindly little nerve that's just as painful. Yeah. So that if they all looked like that, I could see why. Okay, maybe we should excise them, but they don't. And so just simply getting rid of the ligament is helpful about 90% of the time. We've been doing the derm decompression on these for I've been doing them for 20 years now.
Yeah. So the technique that Dr. D is talking about is called your Morton's endoscopic nerve decompression, also known as your endoscopic decompression of interdigital neuritis, EDEN or MEND or whatever you want to call it. Mm-hmm. It's just like how you talk about carpal tunnel surgery endoscopically. Right. You go in, small port, and you literally release the band of tissue that's coming in and over that nerve, giving that nerve some wiggle room. So here's kind of what it looks like. Yeah,
this is there's the one in the picture in the middle. That's the Kobe. So that's a blind technique, which I'm not diminishing. I think there are folks that probably do that quite well. I just don't prefer it because I like to be able to visualize it. I can do the endoscopic technique with a 2.7 millimeter scope where we can actually visualize the ligament in like 8 minutes.
So we're talking about going in literally 2 small ports, 1 centimeter each, and releasing that nerve and having nearly a 90 plus percent success rate.
95% success rate, where you don't need to take the nerve out.
Yeah, versus a 4 centimeter plus incision either on the top or the bottom of the foot, depending on your technique, and you're removing that nerve, and you're going to have residual numbness in that foot, and you'll have the risk of having a stump neuroma,
which could be 10-15%.
Yeah.
So, I mean, that's a big difference. That's statistically significant.
So, what are we looking at? We have a scope here, right, where we have a cannula, which goes in.
Cannula. You've got a retractor that's putting tension on the ligament, because so cutting something that's under tension is just easier than something that's loose.
Yeah, the retractor literally goes in and puts tension and spreads those bones apart, so you can see that band of tissue real taut. And
then the upper right is a cartoon, essentially, but that's showing the knife releasing the ligament, and shows our view because there's a slit in that cannula, so you can see everything above. So the nerve is literally below the
just
cannula.
Below,
protected underneath.
So we'll go in and we'll see. I think we have the surgery here. We'll go in and we'll do our hook test with a little dull hook. Palpate that ligament, make sure it is what we suspect it is, and then we'll go in with the blade and tease away that ligament. And I mean, honestly, 10 minutes maybe?
Yeah.
In and out.
Is that a video of you in residency? Whacking away at somebody's knee?
That's a total knee that I thought was hilarious.
That's great. So yeah, this is really cool. So these pictures are actually from Steve Barrett, who is the developer of the set that I use currently. He's a friend of mine, a very good peripheral nerve surgeon in his own right. And he helped develop the instrumentation that we use, which is, again, very similar to the endoscopic carpal tunnel set.
So here, I think I have one of your surgeries here.
Yeah, awesome. So that we're looking at the white parts of the ligament. So we use a little angled probe to be able to palpate the ligament, just tug on it, make sure that we don't have tendons in the way, because the lumbricaly tendons can get in the way if you're in the wrong layer.
So we're literally, I mean, the scope is very small. I mean, honestly, we're talking about like the size of a pen.
2.7 millimeter.
Yeah, I mean, trying to get in perspective of what people are,
Right.
It's just, it's crazy small. And we're literally, we're hook testing that nerve, that ligament, to make sure it is what we suspect it is, Yeah. And I mean, when it doesn't move and it's nice and stiff, we know it's exactly,
And if you're in the wrong layer, you're going to see muscle, or you're going to see more fat, and you can't really see the ligament. So that's the initial step, is to just verify you're in the right layer.
So we go in, we got our scope, we got everything prepped. Now the next step is to go in with the blade and free up that ligament. So here, I think we got second half of your procedure here.
So this is a specific hook knife that runs right alongside the camera. So they're both in the same ligament, both the same cannula. And you can see I've just released the ligament. You can see the beefy red muscle underneath, and you've completed it. Then I'll take the instrumentation out. I'll put the fascial elevator back in there, which looks like a spatula. And I'll just kind of flick back and forth and make sure I can feel it's gone.
Yeah. I mean, honestly, it's so quick.
So these folks, this is an 8-minute surgery. If I do both interspaces, maybe it takes 10, 12 minutes.
Yeah. So you're literally going in. I mean, just
that's all you're doing. And post-op course, they're back in regular shoes in 3 days. The stitches are in place for maybe a week, 10 days at the most. So I think this is the way to go.
If you're having the neuroma pain.
If you're having neuroma pain, there's no reason to skip this step, in other words. We can always go in and take the nerve out if it doesn't work.
Yeah.
And we give it 6 months. So when I do these, I tell patients, hey, look, we're going to give this 6 months. If you are completely dissatisfied with your pain relief at 6 months, then we know that, okay, it didn't work.
Yeah.
You're falling into a relatively small category of patients that don't respond. Then we can talk about, okay, what are our options for taking it out? And then if we have to take it out, we're going to either plug it in a muscle, we're going to cap it with a porcine submucosal nerve cap to protect it from developing the painful neuroma, the stump neuroma, exactly. We can plug it into bone. That's not real helpful in the forefoot.
Yeah, it's difficult there.
You can do that up in the ankle level, at the knee, but doing it down here, it's just easier to plug it into muscle or cap it. If it's both interspaces, and we've talked about this before, where we can actually use a cadaveric nerve connector
and bridge them together.
And that works quite well as well. So pretty easy procedure. We put two sutures in, one in the interspace, one at the dorsum of the foot where you do the incision for the retractor. They're in a post-op shoe for 3 or 4 days.
Honestly, yeah.
Then they're back into a tennis shoe with a Band-Aid over it. I mean, it's pretty simple. So from that perspective, the downside and the risk are extremely low, and the upside when it works makes this an incredibly effective
And like
procedure.
I said, you're looking at like a 90+% success rate.
Right.
I mean, why wouldn't you try to save the nerve?
Yeah.
It's just this weird technique that's been, just passed down generation to generation. And
it's been around since. You're talking about neurectomies. Yeah, neurectomy has just been the way that orthopedic surgeons and podiatric surgeons have been trained to deal with neuromas for decades and decades and decades. And it takes a while to change that perspective. But I think over the course of the last 30 years, because that's how long this procedure's been around.
It's a paradigm shift.
It takes a little bit of a paradigm shift. Either people are doing it more open or they're using the endoscopic technique. Steve Barrett says he goes over to France and Spain to train surgeons how to do this over there. And they love it because it's so short. They don't have access to OR time like we do here. So not as many hospitals, not as many opportunities to do longer surgeries. So these real short, quick hitter surgeries, they love that. And it's an effective way to address this problem. It's an easy thing to train people to do. So there's a little bit of a learning curve on this, but if you do endoscopic plantar fasciotomies or endoscopic gastroc recessions, it's very similar technique. All
in all, I mean, super straightforward. You're saving that nerve. You're taking the pressure off. You're hopefully relieving that pain for that patient, and quick recovery. I mean, honestly, most of the ones that we do, I mean, they're better in a matter of a few weeks, maybe a couple months max.
Yep. At 6 weeks, if they're still having significant pain, we'll do a steroid shot just to calm it down. But then if you've released the ligament appropriately, then the instigator for all this isn't there anymore. Yeah. So you calm it down with the steroid shot, and then they just do great because there's nothing there to irritate the nerve any longer. So I think a very effective, quick and easy surgery that you should definitely consider before you allow somebody to hack your nerve out. Important safety tip.
Yeah. If you have nerve pain in your foot, talk to your doctor about releasing that nerve rather than cutting that nerve out.
And if they don't do that procedure, you can go to aens.us, which is the Association of Extremity Nerve Surgeons, and you can find a surgeon who specifically has interest in peripheral nerve surgery and may be able to point you in the direction of somebody who does that technique and can help you. And if you're in the Dallas area, you can come find us. We can certainly talk to you about your options. So, excellent, quick, short, just like the surgery. Could have done 4 of them in the amount of time we did the podcast. So, any questions, go ahead and hit us up on the socials. Again, this is a great technique for dealing with Morton's neuroma, otherwise known as interdigital neuritis. And we will see you next time on the PODdoctors.